Hello everyone, today's case is a case for seniors, but I'll start with anatomy so juniors could follow. Let's start with this normal case before we go to the abnormality. This is an MRI of a lumbar spine of a normal adult patient. This is a sagittal view of the lumbar spine. This is the CSF here. It's bright, so this is a T2 image. This is the squared vertebral body, and this is the intervertebral disc. So vertebral body, disc, and so on. Posteriorly here you have the posterior elements. This is the spinal cord as it floats within the CSF contained within the thecal sac. So you have a tube-like meningeal covering that contains CSF, and then you have the cord almost floating within it. Now we'll talk about important nomenclature when it comes to the spinal cord. The spinal cord terminates in a triangular-like component called a conus medullaris. And if you count the vertebral bodies, you'll note that the termination of the cord, or the conus medullaris, terminates at the level of T12L1. So let's exercise that together. If this is the first sacral vertebral body, this is L5, L4, L3, L2, L1. Despite cord termination at the L1 level, you have these linear components that descend all the way downwards. And those linear components float within the CSF-filled thecal sac. Those are actually the nerve roots of the lumbar, sacral, and coccygeal segments. And this collection of nerve roots is known as the cauda equina. Cauda, which stands for tail-like, equina, which stands for horse, so it's the horse's tail. Initially, the nerve roots of the cauda equina are closely packed together, then they spread out to go to their corresponding neural foramen. You notice that there is one line in particular that's dark, connecting the conus medullaris all the way down to the end of the thecal sac. This is a thin terminal thread of connective tissue, and that's why it's known as the filum terminale. Now that you know your sagittal T2 anatomy, going over this quickly, the vertebral bodies, namely the lumbar vertebral bodies, intervertebral disc, posterior elements, CSF-filled thecal sac that appears bright on T2, the spinal cord terminating in the conus medullaris at the level of T12L1, given distal nerve roots that simulate the horse's tail, known as the cauda equina, and the thin cord-like connective tissue line that connects the end of the spinal cord to the end of the thecal sac, known as the filum terminale. Here's the same normal patient showing you a sagittal MRI lumbar spine in T1 instead of T2. Although the same anatomy applies, it's more difficult to appreciate the cord from the surrounding CSF since the CSF is also dark. Now, since we have all juniors aboard, juniors or seniors, have a look at this abnormal case. This is a sagittal MRI in T2 on a 54-year-old female patient. You could see the vertebral bodies, the intervertebral discs, and the intervertebral discs show a little bit of bulging consistent with degenerative changes. You have the posterior elements, and then you have the spinal cord and its related components. The spinal cord terminates in a conus medullaris. The conus medullaris itself terminates at the level of the first lumbar vertebral body. And here you have all the nerve roots running within the CSF, forming the cauda equina. Now, have you noticed any abnormality yet? I'll give you a hint. The roots should be smooth and linear. For sake of completion, I'll show you the T1, which doesn't add much. You cannot see any obvious abnormality. So let's go to the T1 with contrast. And here you go. This is the sagittal T1 of the lumbar spine in the same patient after giving contrast. The abnormality is much more obvious. You see all these nodular enhancing components involving the cauda equina. Here's one obvious nodule which is enhancing and related to the nerve roots. Here's another, a third, a fourth, and so on. Before we proceed to the differential diagnosis, let's see if we could have seen the abnormality on the T2 weighted image. And of course it's tough, but the abnormality is definitely there. You could see all these nodules related to the cauda equina here. This in itself is a very important teaching point for radiology residents. Remember that many lumbar spines are performed without giving contrast. And if you don't look carefully, these could be missed. The teaching point is make sure that the cauda equina nerve roots are smooth and linear without additional nodularity. So what's the differential diagnosis for multiple tiny enhancing nodules of the cauda equina? Now, practically speaking, you have two big major categories. The first is metastasis, and metastasis in this area could be drop metastasis from a CNS tumor above, such as ependymoma, or could be distant metastasis from non-CNS tumors such as breast cancer, lung cancers, and others. Now, primary tumors that give you a nodular appearance like this are rare, so that's not a major differential diagnostic category. In addition to metastasis, the other big category would be syndromatic, in particular neurofibromatosis type 2. And the reason you see these in neurofibromatosis, these are all nerve sheath tumors, namely schwannomas. For better understanding, remember that neurofibromatosis is a neurocutaneous syndrome known as the Miss-Me syndrome. And that stands for multiple inherited schwannomas, meningiomas, and ependymomas. So the multiplicity of tiny cauda equina schwannomas highly raises the possibility of neurofibromatosis type 2. Whether you're suspecting metastasis or neurofibromatosis, it's recommended in both to image the entire CNS axis. And this is what we did with this case. So this is the sagittal cervical spine T1 after giving contrast. Without going into much details, there's this large extraaxial lesion, a meningioma compressing on the brainstem, and an additional meningioma in the upper cervical spinal cord. Remember, Miss-Me, so this is NF2. Now let's summarize what we talked about today. First, we revised the cord anatomy. You have the cord, the conus medullaris, and cauda equina. Second, we agreed that CSF surrounds the cord in the thecal sac and that you could see the nerve roots very clearly on T2. The third teaching point is important for seniors. You have to make sure that the nerve roots of the cauda equina are smooth without nodules, even on a T2 image. And if you suspect that, give contrast. Once you see multiple tiny nodular enhancing abnormalities of the cauda equina, you have two main categories. Metastasis, whether that's from CNS drop metastasis or extra CNS lesions, versus neurofibromatosis type 2. The distinction between those two categories is usually easier when you know the clinical information. And whether you're thinking about metastasis or neurofibromatosis, image the entire neural axis. And by that, I end today's case. Thanks for watching. Your comments are much appreciated, and see you with more cases later. Hi again. Here's a quick teaching case. This is a 30-year-old male patient who presented with fever. This is not a dedicated chest x-ray. This is an image from a CT scan, and this is how a CT scan starts. When the patient initially lies on the CT scan table in a supine position with his arms lifted upwards, the technician then obtains a poor man's x-ray known as a scout image. This scout image is then used to obtain an optimal field of view when the patient is imaged cross-sectionally. That was a quick explanation to juniors to understand what we're looking at here. However, did any of you guys see an abnormality? Given the different technique and the non-standard X-ray, it's very difficult to see subtle findings. So what we could see on a scout image is usually a big or obvious abnormality. Now this is the chest CT on the same patient, and the abnormality is obviously seen in this location. So you have a subpleural consolidation within the cosophrenic sulcus of the right lower lobe. And since the patient presented with fever and leukocytosis, this is consistent with pneumonia. So why isn't a abnormality of such a size obviously seen on the scout image? In retrospect, it is there, it's obvious, and it's located here. On a chest X-ray or a scout image, the lung does not end at the edge of the diaphragm. In fact, the lungs descend deeply within the cosophrenic sulcus and wrap around the hemidiaphragm. That's why you could see lung markings through the diaphragmatic and hepatic opacity here. So don't be surprised if you see a lung abnormality such as consolidation or metastasis through the hemidiaphragm. And this is an extremely important teaching point. When you're looking at a chest X-ray, don't stop here. Look below the hemidiaphragmatic edge for abdominal and for lung abnormalities as well. In other terms, on a chest radiograph, what's below the diaphragm is not only abdomen. So our summary today is the quick teaching point as well. When you're looking at a chest X-ray, look at the lungs and don't forget to look below the diaphragm. Thanks for watching and see you with more cases later.